Okay, we are live right now. Good evening, Dr. Stephen.
Hello.
Today I have a very, very special guest, Dr. F Weiner. He's a board-certified head and neck surgeon, facial plastic surgeon. Is a top 3 trainer for Galderma in United States of America. He's also an international speaker and trainer and a facial ultrasound expert. And that is why I'm hosting this webinar today. He's going to talk with us about the use of facial of ultrasound and duplex ultrasound in facial aesthetic practice. First of all, Dr. Stephen, how did you manage to think about reintroducing this tool in this spectacular way? As I remember, when I first invited you to this webinar, I told you in my country, we are still using those devices for the gynecologists and radiologists. It's not like something that everyone is doing. So the idea of doing a guided filler injection and the use of ultrasound in the management of filler complication, how did you come up with those ideas?
Well, I was introduced to it from a group in Amsterdam called cutaneous.org. And it's a group of around 4 or 5 doctors headed up by Leonie Sheckley. And she's in Amsterdam, but they run a complications clinic in Rotterdam. And I spent 3 days with them, 1 in the clinic and 2 in a course that they have a few times a year. And a light bulb went off and said, this is the future, particularly for treating complications. They run a complications clinic 3 times a week. They see about 15 patients a day when in their clinics. So they see a majority of the clinics in Holland, but also throughout Europe. She probably treats between 5 and 10 vascular occlusions per month. So she's one of the most experienced, and that seems to be the sweet spot for ultrasound, is treating vascular occlusions, because you can really dial in and find that pocket of HA and then dissolve it using ultrasound guidance. So I've been doing it for about
for centuries
over a year.
Yeah.
Go ahead.
Yeah. Okay, there's a little bit of a delay in the sound, so I may hear you after a while. So for centuries, I've been using ultrasound for seeing new tumors, new plasma, and social lesions. What are the uses of ultrasound in our facial aesthetic practice? How can I enroll it in my own practice in doing my own work?
So first off, the ultrasounds that are used throughout the body aren't usually adapted for the face. You need to use the high frequency ultrasounds, and I would say at least 10 megahertz. 18 megahertz seems to be really good, and so does 20 megahertz. So the higher the frequency, the better resolution you get, but you can't go quite as deep. But for the face, you don't need to go that deep. So that's why these high frequency ultrasound probes are so what can we do with the ultrasound on the face?
And you prefer the 18 megahertz, right?
18 or 20 megahertz?
You prefer the 18 or the 19?
Yes, I use 18 or 20. I have the Clarius right here. This is the one that I think is very practical for use on the face. It's all in one. There's no other wires attaching. It's waterproof. It's 20 megahertz. And US, it's around 7,000. I don't know what it would be in Egypt, but it just seems to be in the right price point and the right megahertz. So what can we see with the ultrasound? We can see.
I saw it on your video on the Instagram. You're attaching it wirelessly to your iPod or iPhone.
Yes. So yes, it goes wirelessly through Bluetooth to the iPad, an Android pad, or your iPhone. So it's and the picture quality is great, and everyone could use iPad pictures, manipulate them very well. Some of the older ultrasounds, use different languages called DICOM and so forth, and then low resolution pictures. Even though the quality of the image is good, the way they store it is low quality, very like kilobytes. And we get pictures that are 3 to 5 megabytes using this on the iPad. So we can evaluate the vascular structures of the face, particularly in the nasolabial, the angular, the superficial temporal artery. If you're injecting glabella, which I highly don't recommend, but some people do, the supratrochlear, the dorsal nasal artery, the superior labial, inferior labial arteries, the facial artery coming up over here, and the labial mental artery, infraorbital artery, the transverse facial artery. So you can evaluate all these arteries easily with the ultrasound. You can also evaluate fat pads. And in particular, you could also look at fillers that were placed previously. And some people don't even know what type of filler were placed previously, but the ultrasound has certain characteristics with its echogeneity and its artifacts that can lead you to decide what type of filler was used in the past.
Mm-hmm. I have a question. I heard you, when I saw your video on the Instagram, you were saying that sometimes HA fillers may appear anechoic or hypocolic or isotonic. It depends on what does it appear on, by such an appearance.
Right. So basic terms are echogeneity. How does the object that you are looking at reflect the ultrasound waves? And so HA filler is almost like liquid, and it's anechoic. It really doesn't reflect much of the ultrasound waves. The waves go straight through it, and you don't get a reflection, so it turns out to be very black. However, over time, the HA filler loses some of its fluid, and it becomes more of a thicker gel, and it becomes hypoechoic, and that's kind of a dark gray. And that's also what muscles appear as, because muscles have a lot of blood in them, and that's liquid, but it's not quite. There are some fibrous tissues as well, so that they're going to be hypoechoic. Isoechoic is a light shade of gray, and that's basically what fat is, and the parotid gland is, and so forth. And then you have hyperechoic, which would be white, which really reflects the sound waves, and that would be bone, cartilage, collagen, as well as like fillers, calcium hydroxyapatite or polymethyl methacrylate.
Mm-hmm. So speaking about fillers, and do you use silicone oil filler? Or have you ever seen a case under ultrasound with having a silicone oil filler?
Yeah, silicone oil filler is very interesting because it has a pathognomonic ultrasound characteristic called snowstorm, and basically it spreads. You think you're only putting it in a certain area, but silicone oil spreads a lot further than when you're placing it, and so it's a field effect, and it's hyperechoic on the surface, and then you really can't see anything below because it just blocks out all the ultrasound visualization below. So it's very interesting. Yes, I actually had a patient a week or so ago that said she had silicone oil in her glabella, and I wanted to look at it. And sure enough, it was all throughout her glabella, snowstorm, know instantly what it is. And it also kind of tells the injector, maybe you don't want to inject there because you don't want to upset silicone oil. If it's stable, great. But if it gets angry, it could create a chronic granulomatous problem.
Mm-hmm. I see. Dr. Stephen, how can I differentiate between an artery and a vein using ultrasound? So
there's a couple of ways to do it. One is a vein is not going to be as pulsatile, obviously. It's going to be a more prolonged pulse. as it's, the artery is going to be, and the vein is going to be. You can actually hear this on ultrasound as well, but you can see it with the color Doppler. Another way to distinguish is actually using pressure from the transducer on the area that you're evaluating. And veins are going to be more compressible than the arteries. So if the vessel you're looking at it compresses, it's more likely a vein. There's also another tool that's fairly advanced where you can actually gauge the speed of the blood flow and determine, arteries are going to be much faster, veins are going to be much slower. Now, when you use color Doppler, you're going to see blue and red, okay? And you use the mnemonic BART. Blue is away, red is towards the transducer. It doesn't mean it's artery or vein. So if you're convinced that something you're looking at is an artery and it's blue, there's a little button on the ultrasound that allows you to do what's called color inversion and change it to red. And that's sort of common for arteries in the medical field.
Mm-hmm. I see. So you were saying that with the use of ultrasound, we can also see the fat. So if a patient had an autologous fat transfer for the under eyes or any area of the face, can we assess, can we visualize it on the ultrasound?
Certainly. You can ultrasound anything, so, that's been injected, but you can also visualize the superficial and deep fat pads that are anatomic in patients as well. So particularly notable is like the intermediate temporal fat pad of the temple, or the lateral temporal cheek fat pad, which is more superficial. And then there's fat pads obviously all over in the nasolabial and the lips as well. So you can visual. So they're going to be isoechoic. So they're going to be a light gray.
Okay. But this is amazing. I mean, we can assess the fat before and after Kybella or Aqualex injection to see how much the fat cells have been burned after our intervention. There's something when I was watching your video, you said that the angle of the rays differs. I mean, if the object is like this and the rays are going like this, the object may not appear. So do you do any angles, or do you move your hands with the probe you are using to visualize certain anatomical locations which may not be in the same direction of the beams of the waves?
Yeah, that's a really good point, fairly advanced. But when you're using these high frequency ultrasounds for the face, they use something called a linear array. And so the waves come out in an array that are perpendicular, okay? There are other ones that are used that are convex and so forth that send out the sound in different angles, but these send them out directly like this. So if there is actually something that is parallel to those ultrasound waves, you could miss it, or it's hard to see. And mainly those are in the face, I find the retaining ligaments. So what you can do, instead of going straight, you could angle it a little bit and you get a better visualization of the retaining ligaments. Now, it's 100% opposite for vessels, interestingly. So if a vessel is going like this, what the vessels are evaluated by changes in the in the wave that's reflected. So if a vessel is going like this, the ultrasound can't pick up the change in velocity. Okay, so that is the worst way to evaluate a vessel. The best way to evaluate a vessel is like this, because it can, it's a little complex, but think of when you're listening to a train and the train has a different pitch as it's coming towards you and as it goes away from you. So it's going to change the frequency of what you hear, right? So it's going to change the frequency by the vessel going towards the sound waves. It's going to change the frequency, and if it's going away, it's going to change the frequency. But it's not going to change the frequency if it's going like this. So there's ways that you can, if you have to put the ultrasound like this and you're perpendicular to it, there's settings on the ultrasound called color box steering, and you actually artificially change the wave so it's at an angle, and the angle should be 60 degrees or less to the vessel to get the best result. And there's a Doppler equation that uses cosine and so forth, but basically you want to not be 90 degrees, you want to be 0 to 60 degrees to a vessel. So yeah, there's intricacy. It's not that easy to pick up, but that's sort of the more complex ways to look at ultrasound.
Mm-hmm. So if I'm going to speak about the dorsal nasal artery, how will I place my probe?
I'm going to take off my glasses here. So the easiest way to look at a vessel is if you're looking at the vessel like this. So because you have a wide foot plate. If you're trying to get the vessel like this, it's a lot harder. You can miss it. So sometimes what I do is I look for a vessel like this and I find it, and then I turn it like that once I find it to go along, so I get the long axis. So I'm going perpendicular to it, and then I turn it to the long axis. The long axis is going to give you the most view, but it's the hardest to find initially. So the dorsal nasal artery is usually paramedial. It's not exactly in the midline. It's off to the side, but it can be in the midline. And so I'm obviously doing something like this with a lot of gel. Okay, so, and it's going to be very, very shallow. I find that it's often 1 millimeter, maximum 2 millimeters deep, and there's not much distance between it and the bone, usually less than 1 millimeter.
Mm-hmm. I do know well that you have a special opinion about liquid rhinoplasty. You don't prefer this intervention, right?
Right, and I have several documented ultrasounds showing that there really is very little margin of error. One of my images shows 0.6 millimeters between the bone and the artery. I mean, that's almost the length of a bevel of a needle. So you really don't have much leeway there. And most of the occlusions, particularly eye complications, are due to nasal injections and glabella injections. So I think the safest way to stay out of trouble is to not inject those areas. But I know it's very popular. So if you have to do it, inject very slowly and very small quantities, and maybe use ultrasound guidance as well.
Mm-hmm. Do you prefer the technique of loading your insulin syringe with your filler and doing the injection, or you prefer to use a cannula?
Interesting study that recently came out in December 30th in the Derm. I don't remember the exact journal, but it talked about needles versus cannula safety. And it just came out, and there's a lot of discussions now about it. And it said that basically cannulas are 77% safer than needles. So I use cannulas almost exclusively. If I'm in the lips, sometimes I can get a little more precision in the vermilion border or something with a needle. And in those cases, I do sometimes use the BD insulin syringe. I also like to use that when I'm injecting for acne scars in the dermis. Obviously, cannulas can't inject dermis, so needles have to be used when you're injecting the dermis. And I do feel that certain fillers do better when they're injected in the dermis than below, like let's say, some of the HA fillers do. So I don't use needles that often, but if I do, I am frequently doing your technique.
I see. Do you know that you are the one who is responsible for inspiring me to use the soft fill cannula? I've seen your amazing videos with the soft fill cannula. So why is it your favorite?
So I've been using soft fills, I don't know, 7, 8 years, maybe 9 years. I tried them all and found that soft fill has the largest inner diameter compared to the outer diameter. So they've been able to engineer the cannula so that the extrusion force is the least per gauge. So if you have like a 27 gauge and you have a competitor and you have soft fill, you're able to push less force with the soft fill than the competitor, which means you have a little more control because you're not straining to extrude the product. The other thing that they have that none of the others have, and they won't because it's proprietary, is their Easy Guide system. Because I found that when using cannulas, some of the hardest part is getting into the skin. And the Easy Guide allows you to get in underneath the skin very quickly. They also have a huge variety of lengths and gauges and so forth. So, you know, something for everyone. There's even one that's really short that I use in the chin. It's a 30 millimeter, 25, I think. Yeah, it's a 25, 30 millimeter. And I go straight down to the periosteum and I go a little bit left and right. And I don't always use that for the chin, but it's a nice one for the chin as well.
Yeah. Actually, I started using soft fill cannula after seeing your videos, and I've been teaching it in my own courses here in Egypt, and I just love it. It's definitely much more safer, and it's very precise. I want to ask about one more thing. There is, for a little bit of time, there was this struggle or this dilemma between the tenting technique of the lip fillers versus the original technique of doing a linear threading in a horizontal fashion. I don't know if Dr. Harris claims that the tenting technique tends to make the filler spread along the skin border. Have you been able to scientifically or to prove this using ultrasound?
You know, I use both techniques, and I actually use cannula technique probably the most frequent. If you have a very thin lip or an elderly lip, it doesn't look natural for them to have a lip filled using the tenting or Russian technique. So I think it's safer in the very thin lip because the margin of error between your injection and the labial artery is much smaller because they lost fat. So sometimes I will inflate the lip using cannulas, and then I go back in if I want and do a little bit of the tenting. Personally, I haven't seen the difference between cannulas or needles or prior techniques leading to anything different with the filler. And I know that there's a debate now about those techniques. I do think that the tenting technique gives an exaggerated vermilion border, which is attractive in some patients, but if you use Dr. Harris's scale, it might actually fall into class 1 or class 2 when it actually looks good according to the patient. So I think it's all in the eyes of the beholder. I can't see how that technique would lead to more bleeding above the lip in the ergotrid area. I haven't seen that with, let me rephrase that. I haven't seen that with appropriate filler. I do think that there are some fillers that tend to migrate, okay? And that in particular, the Allergan Juvederm family tends to do that. And I think that whatever technique you use, I think that particular filler does tend to move. And in some cases in the States, they call it Movaderm and not Juvederm. And I think that it's a filler that is extremely forgiving, meaning it will spread and it won't create nodules or clumps. And that's one of its attractiveness. But if you're a more precision type of injector, I think it's not the best filler to use.
Mm-hmm. So what I meant to ask about with the ultrasound, you can also view very old fillers. I mean, may a patient do a filler under the eye and she did it from 1.5 years or something, and it's still there when you do the ultrasound device, right?
Yeah, and Mobin from Australia has been doing a lot of studies with duration of filler, and we got to rethink our duration of filler, because even in the lips it could last a long time. But yes, that's probably one of my biggest uses of ultrasound. Someone comes in and they have swelling around their eye and they think they need surgery because of eye bags, and you go in and look and say, no, it's filler. And it's really easy to see the difference between fat and filler because of their echogeneity is different, meaning the fat appears light gray and the filler appears dark black. And you go, no, you know what? I can fix you in a matter of 10 minutes, but I haven't had filler up there for like 5 or 10 years. I go, well, it's still there. And so I probably do it once or twice a week that I find someone with old filler there and dissolve it. And I'm not saying that, it happens to everyone. It's not a bad injector necessarily. Sometimes it's the wrong product. Like I said, I want a product that likes to stay in place around the eye because there is a lot of movement filler there. So again, I don't think Juvederm is the right product. It also causes chronic swelling in some patients. But I like to use Restylane there. There is even cases that it was placed perfect, and for some strange reason, it became swollen and moved a little bit, and it just needs to be dissolved, even in the best injectors cases, even in mine. So I'm not saying it's necessarily a bad injector. It's just something that we're realizing happens around the eye that we didn't realize before.
Yes, and there is always that there are some products that have a certain radiological properties with a natural tendency of being accumulative in our own body. We do have a question here from Edwin. He is asking you, Dr. Stephen, do you ever use the needle enhancement feature in the Claris 20, and if so, for which scenario?
No, I don't have the needle enhancement on the Clarius. I'm going to ask them to get it. So the needle enhancement is interesting because what it does is when you're doing needle-guided injections, it makes the needle more visible. And how it does that is it kind of changes the angle of the waves. So again, you want to be perpendicular. So the needle's going in like this. And if the waves are going in like this, it's not quite as good. But if the waves are going in like this, you get that perpendicular effect where you see the needle and it appears more white, hyperechoic, and it's easier to see. That's the whole point of these needle enhancements. I do have the needle enhancements with my GE and Logique, and it does help definitely. When I don't typically inject newly placed filler using needle guidance. What I will use needle guidance for is when I'm trying to improve vascular occlusion, or if I'm trying to dissolve previously placed fillers. So I think that if you are concerned regarding the area that you're injecting, like in the piriform area around the nose, piriform aperture, or maybe in the temple, you can do needle guidance with your ultrasound during the injection. But in my opinion, it adds a little bit, well, it adds a lot more time and complexity to the injection. And it's kind of messy because there's gel around, and you need to become sterile now with the gel. You need to put a probe on the ultrasound. So there's a little more work to doing ultrasound guided injections.
Mm-hmm. I see. Doctor, you were saying about the when speaking about the Doppler, that red means that the flow is toward the transducer, and blue means it moving toward away from the transducers. When there is a vascular occlusion, despite the fact that you can visualize it using ultrasound, does the blood flow changes in this area where there's occlusion? Does it appear on the ultrasound image?
That's a great question. So yes, and you can use that to your advantage. Let's say there's a patient in your office and you're concerned there's a bruise or is it occluded. So you take out your handy ultrasound and you look at it and you look for vascular flow. So if there is definitive flow, then there's no occlusion. Sometimes you can get turbulent flow. And what that is it's swirling around and it's not flowing like it should be. And then you get a mixture of the red and the blue. Or you can get no flow, zero. Mm-hmm. And sometimes you have to compare it to the opposite side as a control, because sometimes maybe you're not in the right place to looking for the vasculature. But so the other side usually is a control. So, oh yeah, it's right. Here's the angular artery. Okay. The other side, it should be similar. It doesn't have to be, but close. And you're not seeing the flow. And if you're not seeing flow, the skin looks abnormal, and you have a suspicion for vascular occlusion. You probably do. And then with ultrasound, you can often find the little pocket of HA, and you can do a needle guidance and dissolve that little pocket. And if everything is going right, you'll be able to establish flow that you can see on ultrasound immediately. And so you don't have to do repeated injections. You can do the injection and see the flow and say, hey, I think I got it. I'll see you back tomorrow. It's my opinion, okay? And this is going against the grain a little bit. But I feel that the injections of hyaluronidase around a vessel aren't nearly as efficient as injecting within the vessel. First off, I don't believe that external compression of filler causes vascular occlusion. It's intravascular.
I agree with you. Yes, I agree with. Even when we do submandibular surgeries and we do a ligation for a blood vessel, we never see an occlusion. It must be you are injecting in the lumen of the blood vessel your filler product to do a vascular occlusion.
Yeah, I agree. So there's actually one interesting study, and I have to go through this because this is so. De Lorenzi says bathe the vessels, and because the HA goes transarterially, it goes through the arterial wall. But there was a recent study done on abdominoplasty patients, so they were going to take the skin away. But before they did, they isolated some vessels in the abdominal wall, and they tied them off, and they injected hyaluronic acid within their lumen. And so they bathed those vessels with hyaluronidase, and they saw no dissolving of the intraluminal HA product. They did this several times, I think on five different arteries. Then they injected within the vessel, and it dissolved immediately. So the feeling was that the De Lorenzi study was done on cadavers, and the basement membrane of artery changes as you die within 15 minutes. So the penetration of the hyaluronidase is completely different in a cadaver specimen than it is in a live specimen. So the other thing that backs me up is that when you take hyaluronidase and you try to dissolve filler like in a petri dish, it does it rather quickly and rather easily. Why are we injecting hundreds or thousands of units for a very small amount of vascular occlusion it's probably because it doesn't really get into the vessel very well. It does if you get enough of it, it's going to go by osmotic pressure. But so that's why the ultrasound getting into the vessel with a needle, because you're not going to get into a vessel with a cannula very easily, and dissolving is the key to success.
Mm-hmm. So I guess if we used a guided hyalase injection, we will be using a less more of hyalase than we usually do without an ultrasound.
100%. I hate to give you these stories, but when I was in Rotterdam, when I was at the complications clinic at the Erasmus Hospital with Leonie, she was called, and she gets called all throughout the day and night. She does God's work about these occlusions. She was called late the night before about a nasal vascular occlusion. And she said, look, it happened a day ago, inject it with 3,000 units of hyaluronidase, and I'll see the patient the next day. So we saw the patient the next day in the clinic. In the clinic, the nose was obviously still occluded. We found the area of occlusion. She ultrasound guided, injected with hyaluronidase, 120 units. And it cleared, and we saw flow, and we saw her the following day, and her nose was normal, big smile, so 3,000 units, throwing it like all over the place, no good. 120 units in the right spot, perfect.
Mm-hmm. Yes. What's your recommendation about the capillary refill test?
I think it works. What you have to do, according to a study I saw, you have to hold it down for at least 5 seconds, maybe even 10 seconds. Don't just go like this, okay? That's not going to do it. Hold it down and then release and see how fast it goes from there, okay? I do think it's a good, when you have no other tools, it's good. I think if you can't afford the ultrasound, one other tool that you might want to consider are the pocket Dopplers. And those are the ones that you use to evaluate for like blood flow in vascular flaps, or even the baby's heart rate. They're about $150, and it goes, so it's just audible. And again, you could do it on one side, and then you could do it on control on the other and see if there's any flow. So I tell people, if you have to can't afford the 7,000, at least get that. It's better than nothing. And then if you're doing the capillary test, hold it down for a while, 5 to 10 seconds before you lift.
I want to ask you about some of your own personal experiences. What are the most bizarre anatomical variations that you have encountered using ultrasound regarding the arteries and the vessels?
Oh,
I've seen one. I guess it was facial artery at the corner of the mouth. It was like pulsating like this, and I was wondering if I was gonna do a cannula injection for her. She was probably gonna bleed to death.
Yeah. Matter of fact, that was a very interesting case. So she goes, I have a bump here. Can you inject around it? And I started looking at that bump, and it was pulsing. And she's a very thin woman. Her skin was extremely thin. And I said, you know what? I want to ultrasound that. And in fact, her skin was 1 millimeter thick, and the vessel was probably about 1.5 millimeters or 2. It was over here. It was the facial artery before it branched. You wouldn't need an ultrasound for that. There's also a lot of anatomic variations of the labial arteries that sometimes you can see pulsations with that. I saw a real interesting case with someone that was injected in the temple, okay, with the gunshot technique, which is down to the periosteum. I don't like to do that technique either. I like to do a cannula technique in the interfacial plane. But anyways, she had it done somewhere else. I said, I'd like to look at it.
Actually,
And so I looked at it,
the
and
more you know about complications, the more they use the cannula. So I don't use the gunshot.
So the radius, the calcium hydroxyapatite, was sitting in the temporalis muscle. It was just free floating. And when I asked her to clinch, you could see it just move around inside. So it wasn't giving any improvement whatsoever. I also don't think that does give improvement, because that periosteal injection spreads a lot into that temporal fossa. And then I did further evaluation looking at the vasculature, and it was wrapped around the deep temporal artery. So little did she know, she was almost blinded by a technique that actually gave her no useful enhancement. So that was an interesting case too.
So regarding the temple, you always use the cannula. Do you do a sandwich technique, a dual plane technique, or just inject it superficially using the cannula?
So if you're going to inject in the temple, my two techniques are injecting in the superficial plane, which would be superficial to the vessel subcutaneously. That's the easiest plane, but you are going to have visible product sometimes, so you have to use a very thin product there. So what I do is I take Restylane or Lift. I like to use an easy to dissolve filler there, just in case there is an issue. And I dissolve it, I dilute it with either 1 or 2 cc's of saline, maybe a little lidocaine. The other plane that I use more often is the plane between the superficial temporal fascia and the superficial layer of the deep temporal fascia. So between the SMAS and the deep temporal fascia, there's a avascular plane, and that gives you a little more buffer between the skin and the filler, and it will be below the superficial temporal artery, which is in the superficial temporal fascia. And I used a 22 gauge cannula.
Yeah. Yes, always 22 or 25. 27 gauge cannula acts as a needle. I totally agree. We have a question from Edwin. He is asking about which artery do you think was compromised in the case that you were speaking about Julie, when she used 28 vials for a Hylenex.
Oh yeah. That was obviously the transverse facial artery. And as a matter of fact, when I evaluate people for that transverse facial artery, it is actually a very superficial artery, particularly in the submalar area right here. It could be immediately subcutaneous. So I actually think that that's one of the more common areas that people have had problems with it. There's another artery that is to the zygomatic ligament. The main zygomatic ligament has an artery as well. But I think it was the transverse facial.
Have you ever encountered any complications regarding the zygomatical facial artery?
I have not, but Leonie has. She stated that she had retrograde into these. It went deep, and it went into the zygomatical temple, and she was able to clear it using hyaluronidase. I haven't seen that. That is a problem. So you're going to have that zygomatical facial that it's right here. So it should be a little bit anterior, a little bit higher than your usual cheek enhancement. But if you're injecting around the eye, it could be encountered.
I see. I want to ask you one more question. Do you think is it easy for anyone to use the ultrasound, or it needs like a lot of practice?
So the course that I took, and I'm going to be giving courses throughout the U.S. as well. It was about a 2-day course, and it's an introductory course, and it gives you the how to look for vessels and so forth. But it really takes a lot of homework. And when we had COVID and we were at home for 6 weeks, I ultrasounded all over my face, all my family, almost 24/7, and got really good at it. I was very fortunate that we had that downtime. And there's some things that are online that you can look at on YouTube, and on Pinterest actually has a lot as well to help you out. Nothing particular to the face that you're going to find very much, no, but just the science and the physics and the knobology, meaning how to manipulate the ultrasound to maximize your visualization. You can find a lot of that online, because ultrasound is the future, not only in aesthetics, but in the ER, in the paramedics that are going to accident victims. Sometimes you're going to see them treated. In third world countries where they can't afford to get CAT scans or MRIs, all you need is an iPad and something like this, and now all of a sudden you can diagnose heart problems, liver problems, and so forth if you're really good. So ultrasound is the future. Things are becoming less expensive, more compact, and I think you're kind of missing out if you're not incorporating it in your practice now, because there's going to be potential liability if so-and-so uses ultrasound. Why aren't you using it? In my practice, I have a cardiac defibrillator in case there's a problem with the heart on some patients. Well, fortunately, I haven't had to use that, but I think that, but almost every clinic has something like that. So you're injecting every day. I think you're going to have much more use out of an ultrasound than you will out of a cardiac defibrillator. But get both is what I'm saying.
Totally agree. Totally. So when will be your first one-to-one training?
So there's something called the Academy for Injection Anatomy that I will be doing a monthly seminar. It's not going to be strictly on ultrasound, but it's going to include an ultrasound didactic as well as hands-on. But in the future, if you want more individual training, it won't be individual, it'll be a small group. You can contact my office, and we'll be doing small groups of anywhere from 5 to 10 people in the office. And that will be a day-long course. We haven't yet set up those times yet. Due to COVID, we've had to delay it several times. And international people are wanting to come, but
are you intending to do? Yeah.
Pardon me?
I will be one of the first to come.
Okay.
Are you intending to do any online courses or virtual trainings?
I think I might actually, but I think the most value is getting hands-on and helping you, with the positioning and all the different settings. I can go through it, but the real proof is doing it hands-on.
It's better. Yeah, exactly. It's more better. Yeah. We have a question from Ahmed. He is asking you if the AccuVein or vein viewer flexor is effective like the ultrasound, or it's not.
No, you're only going to see very superficially, and you're only really going to see veins. The arteries walls are too thick to actually be seen with those. So I use that When I'm in my IV bar, when we have difficult IV sticks, usually we can see veins well that way, but not for vascular occlusions. No, it's not. It's not helpful. And those run.
Mm-hmm. I see.
Those run. They're almost as expensive as something like this. So if you're considering one or the other, don't even get that. But
I see. So, Dr. Stephen, what is your preferred approach for the piriform foci?
So I use cannulas in that area, and there's two ways that I do it. The best way to, or the safest way to approach any area is if you're perpendicular to a vessel. Because if you're within a vessel, you're going to be out of a vessel because you're going to be constantly moving for a very short time. If you're injecting parallel, you're more likely to cause a problem. However, I will inject the piriform two different ways. So sometimes I will inject from here with the cannula and go underneath this way, and I'm perpendicular to the angular artery. And you could either do that superficially or deep to the vessel. The vessel is going to usually be right in the middle. Now, if you had ultrasound, you can tell that, and you can decide whether you want to go superficial or deep to it. There is actually approximately 1% case that the artery is actually along the periosteum. That was a Korean study. So even though it's highly recommended to go down to the periosteum, aspirate, and inject, in 1 out of 100 patients, you're actually going to be injecting into the vessel. A negative aspiration isn't necessarily freedom that you're not in a vessel. The other way I inject the piriform is from the nasolabial, and I go up and inject that. I'm usually injecting all around the nares, even to the columella area, because it's not just the one area that's affected. So the whole ergotrid and maxillary area needs to be injected, as you know, being a maxillary surgeon.
Yes, exactly. But you are gonna use a soft filler here, not in order not to give her like a chipmunk appearance, right? You don't want to make her like this. Do you have any experience about the RHA products?
Yeah,
we don't have it here yet in Egypt.
Yes, we got RHA about 3 or 4 months ago, and actually it's a very nice product. We have 2, 3, and 4, and they are very smooth. They integrate very well. I put them mostly in the lower face. Those products don't have a lot of G prime, so I don't do a lot of lifting. There's controversy over lifting, but I don't put them much in the areas of the jawline or in the cheek area. So mainly nasolabial, sometimes in the lips. Marionette, very good for that. Radial cheek lines, and sometimes even acne scars.
Yeah, and you also place it on the neck along with hyperdiluted radius and radiofrequency microneedling, right?
Mm-hmm.
Okay, thank you so much, Dr. Stephen, for sharing your knowledge on this beautiful evening. It was such a pleasure, and it was a great honor for me. Did you ever come to Egypt before?
No, I haven't. If I do, I'm going to look you up.
Hopefully. Yeah, sure. Hopefully, when this whole COVID things ends up, we will be able to invite you here to Egypt to share your knowledge. Thank you so much for this webinar. I'm sure that everyone have loved it. I'm going to save it. I'm going to send it to you tomorrow morning, hopefully.
Perfect. Thanks for inviting me. I had a great time.
Okay.
Bye-bye.
Thank you so much, Dr. Stephen. Thank you so much. Bye-bye. Bye. Thanks, everyone.